Good evening, good afternoon, good morning, depending on where you're connecting with us from. I'm very pleased to welcome all of you to this webinar on mental health and COVID-19 in humanitarian crisis, brought to you by United for Global Mental Health, the Mental Health Innovation Network, the Lancet Psychiatry, and MHPSS.net. This webinar, as you might have noticed, is being recorded, and we'd really like to invite you to tweet your comments using the hashtag COVID-19MH, or all caps. Some of the panelists actually will be online after the webinar to interact with questions for about 15 or 20 minutes after the session. So we hope you'll stay on for that as well. My name is Anand Galapati, and I'm the co-director of the online platform MHPSS.net. Today's webinar speaks directly to the constituency that MHPSS.net works with in humanitarian settings around the world. We have, over the last few months, been very aware that the way that the COVID-19 crisis plays out in situations of conflict, disaster, or pre-existing humanitarian health crises like Ebola has been distinct from other settings. And we're therefore really, really pleased to present today's panel with both practitioners and researchers who've been active in the field across a variety of settings. I'm pleased also to introduce the chair of the session, Peter Ventevogel. Peter is a psychiatrist and a medical anthropologist, and since 2013, he's the senior mental health expert with UNHCR, the UN Refugee Agency. So over to you, Peter.
Okay, good morning, afternoon, and evening. Can you all hear me well? I think so. So great. So today's webinar will focus on mental health and COVID-19 in conflict situations, or more generally, the effects of the COVID pandemic on people in settings with pre-existing and ongoing humanitarian situations. Now, the format is as follows, pretty straightforward. We have a round of introductory remarks by our four panelists, followed by a second round of questions where we can go a bit deeper into the issues and then have a set of closing remarks. So I would like to remind you about the hashtag. We have the hashtag COVID-19MH, all one word, which would be great if you could use that in social media. A little bit I hear funny noises here. Why is that?
Could I just ask all the panelists to mute their microphone, please? Everyone except Peter, thank you.
Exactly. Okay, this is much better. I don't hear the echo. So yes, a violent conflict has forced many people to leave their homes, and my organization, which is UNHCR, estimates that there are around 71 million forcibly displaced people worldwide, among them 26 million refugees, around 4 million asylum seekers, and most of them, 41 million, are internally displaced people. Important also to mention is that most of them, the vast majority of those, are in low and middle income countries. So today we will particularly focus on humanitarian settings in particularly Africa and the Middle East. But there are forcibly displaced people on all continents. Think of the Rohingya in Bangladesh, the Afghans in Pakistan, Iran, Venezuelans in Latin America, but we will focus mainly on Africa and on the Middle East. Now we have eminent panelists today. They all have long experience in humanitarian mental health and psychosocial support, or MHPSS. And I may need to explain that a little bit because we use, in humanitarian work, we use the term mental health and psychosocial support, MHPSS, which is a little bit of a horrible acronym, but it's important because it indicates all activities that we do to promote and preserve psychosocial well-being. It could be outside of the health sector, as well as activities related to mental health care, which are often within the health sector. So we will use this acronym MHPSS. You'll hear it a lot. So without further ado, I would like to start with introducing the speaker one by one. I will introduce one speaker and then go on to the question. So I will start with Ken Miller. Ken is an American psychologist who lives in Amsterdam for a while already, who works with the NGO War Child Holland, and there he's involved in developing and evaluating mental health interventions with refugees and other war-affected communities. And he's currently involved in research around caregivers in Syrian families in Lebanon. So I'm very pleased to have you, Ken. I would like to say one more thing about you, because around 10 years ago, you wrote a very influential article in Social Science and Medicine, together with Andrew Rasmussen, and it was called War Exposure, Daily Stressors and Mental Health in Conflict and Post-Conflict Settings, Bridging the Divide Between Trauma-Focused and Psychosocial Frameworks. Now, that has had a tremendous impact. I learned a lot from the article. I would like to tease you a little bit, because this issue of the importance of events of the past versus the current life circumstances continue to linger on in the humanitarian world. And sometimes I hear my colleagues saying the Syrian refugees are now double traumatized. They're traumatized because of the war, and now they're traumatized because of COVID. In your remarks about the Syrian families in Lebanon, could you also address this issue of trauma versus daily stressors a little bit? Over to you, Ken.
Sure. Thank you, Peter, for that nice introduction. You know, a lot depends on how we use the word trauma. There are Syrian refugees who really are struggling with the psychological trauma because of what they lived through in Syria before they got out. And by psychological trauma, I mean the way we think about it clinically, with flashbacks, intrusive thoughts, the inability to relax, avoidance of all kinds of reminders. It's sort of classic PTSD. But the term trauma gets used much more loosely in ways that I think can sometimes be problematic. So I hear and read a lot about how Syrian refugees in the camps and settlements in Lebanon are traumatized by the pandemic, and I think that that's a bit problematic. I don't think they're traumatized on the whole by the pandemic in any sense of PTSD trauma. Anyway, it maybe if what we mean by traumatized is really distressed, then absolutely. But I think it's worth making a distinction, because trauma, PTSD, really represents a reaction that persists after horrible events have come to an end. The effects are still there. That's how we think of post-trauma reactions.
Right.
What we see among Syrian refugees in Lebanon is an extraordinary level of stress right now, but it's not primarily PTSD about the war. These are families living in abject conditions. Many of them one step away from being evicted from apartments that they can no longer afford. These are families where parents can barely afford to feed their children. And now these are families who are being reminded on a daily basis through all kinds of messaging that there is a pandemic out there that could kill them, that could make them, their children, themselves very sick. And they're being told what to do to stay safe, except that a lot of those families don't have access to the resources to engage in those safety mechanisms. So when you're told, I saw one message for Syrian refugee families that reminded them that they could use hand sanitizer. I can assure you they don't have access to hand sanitizer. Most Lebanese don't have access to hand sanitizer, sold out months ago. Soap and water. In the survey we just did, about 40 to 45% of the families reported that they did not have access to clean water and soap. So when you're being told that this very dangerous virus can be avoided by washing your hands 10 or more times a day with water and soap, and yet you don't have access to that, what happens is we inadvertently intensify the sense of fear and vulnerability. First, here's the danger. Here's what you need to do to stay safe, except that people can't do those things. So I think when we want to understand what's going on in these families, we need to move beyond this language of people are all traumatized and understand that they are stressed in response to real world conditions that we can change. And we can have a very powerful and fairly quick impact if we think about making sure that people have basic resources that they need to stay safe and healthy.
Okay, that's very illuminating and very helpful. Thank you very much, Ken. So what I understand is actually you would say the major issue among Syrians in Lebanon now is a general distress. People are fearful about how they shall cope with the situation. Do you see specific issues that you would like to highlight?
I would say, I mean, most immediately with regard to COVID-19, we need to make sure people have access to clean water and soap.
Right.
We need to make sure that people are not being evicted from their homes because Lebanon is also going through a financial crisis. And we need to prioritize in our messaging those things people can do. Social distancing can be very difficult in a tented community, but not touching your face is very doable. So we need to tailor the messages that we're sending to things that people can enact. That's what I would say.
Okay, thanks a lot. That's very helpful. I will pass on now to our next panelist and come back to you, Ken, later, because we want to hear more, definitely. I'd like to go to Deborah now. Deborah, hi, you are a clinical psychologist from Indonesia, and you have a long career in psychology, over 10 years, working in different humanitarian settings in Thailand, Indonesia, and South Sudan. You're currently in Nigeria, where you work as the coordinator of the MHPSS, Mental Health and Psychosocial Support Working Group in Northeast Nigeria, in Maiduguri. Now that is the capital of Borno State where you work, and that's a place that is famous for, or infamous, I should say, for the violence that has happened there. Could you tell a little bit about how COVID-19 has affected the mental health state of the people in Borno State? Over to you.
Thank you very much, Peter. Yes, so it's really interesting to hear Ken and the experiences in other side in the Middle East. So maybe I can share on the context a bit more to the Africa, and this is more to the West Africa. So with regard with the COVID-19 pandemics and the impact to the mental health and psychosocial support. So in related with the response in here, so mainly we have a lot of partners, and IOM and other partners and stakeholders are providing the interventions in 3 states actually, as Peter already mentioned. Like, so Borno is one, and we have also Adamawa and Yobe State. So we are supporting the governments and of the Nigeria through the State Ministry of Health and other relevant ministry, and coordinating the activities with other sectors such as like health, job protection, GBV, camp coordination and camp management, education and livelihood. So currently we have like around 49 MHPSS partners from national NGO, international NGO, RCRC movement, UN agency, and government institution. So maybe just briefly on the context of the Northeast, because this context is continued to cause like suffering to millions of Nigerians, and particularly for women and children. So referring to the humanitarian response plan in 2020, so we have a total of 7.9 million people in need of life-saving aids, with women and children constitute of like around 81% of the overall crisis populations and 87% of the new displacement. So it has major impacts to the overall living standard, physical, psychological well-being, and the capacity for resilience, and having positive coping mechanism for the IDPs, returnees, and communities. So their issue, such as a congested camp, increase of fire outbreak, flooding, lack of access to potable water, sanitation and hygiene, food security, malnutrition. We have also limited access to the health facility, a lot of multiple disease outbreak before, an increase of sexual violence and abuse. So with this already existing challenging condition, so the COVID-19 is increasing. Yes.
No, you go ahead. So I hear you explaining all the issues, and then I would say, does COVID-19 have an impact? Does it make a difference? Over to you again.
Oh yeah, that's true, because this is the thing. With this already existing challenging condition, so the COVID-19 is increasing the psychological distress. So I like what Ken already mentioning. We're not using a lot of like trauma words in here. There's a lot of, you're increasing the psychological distress among the affected population. There are anxiety, fear, confusion, and maybe also frustration. So they also worried about the health of their own and also the family members, as well as not having access to the food, and also issue with economic hardship or lack of livelihoods. So there's cumulative also family tension and also intimate partner violence. So the people are also worried. This is the thing, to visit the healthcare facilities. due to the high level of stigmatization, because there's a label in here, it's called like quote unquote Corona house, given to a house with a family members living with a COVID-19 positive. And also there's another issue in related with the movement restriction, for example, and the lockdown being taken by the government. So it's created a lot of like major consequences on delivering the MHPSS response. We understand that there is a number of psychological distress and other related mental health conditions, and also the use of substance drugs or local drugs, and limited access to the clinical care for people with pre-existing mental health conditions. So the current MHPSS approach that we are using here is evolve and it's adapt to the needs of the population, and the program is prioritizing mainly for the remote support, remote counseling services, or peer-to-peer support living in the same household. So at the onset of the pandemic in the Northeast Nigeria, the MHPSS intervention were not considered as the most important areas compared to the other pillar response, such as contact tracing, surveillance, case management, or infection and prevention and control. But now it's totally different, because
That's
we have been
interesting.
requests.
Okay, I'll
So,
get back to you in a minute, but it's very interesting
Sure.
what you say, because actually you say that initially in the response, mental health and psychosocial support were not so visible, but it's actually getting stronger in among the needs, and that's what I hear in other settings too. And I would like to check with Phiona how that is in another area that has quite some of the problem. So, Phiona, you are a psychologist from Kenya. You are working as the Senior Technical Advisor for Mental Health and Psychosocial Support at World Vision International, one of the largest NGOs in the world. And, well, you've worked for over 15 years in humanitarian and fragile contexts. But that didn't make you a bureaucrat at all, because you're traveling all over the world. I saw you in the last 6 months. You went to Myanmar, you went to several places, and you also recently went to DRC, to East Kivu, where a lot of things are going on. So could you tell me a little bit about how the COVID-19 made a difference in the Kivus, where actually they had all the problems you can think of, they had them already. Over to you.
Thank you, Peter, and everyone. Yes, for North Kivu, I could just use simple words: fear, isolation, stigma. Just what has been happening in North Kivu with the Ebola response. As we all know, North Kivu has been battling with the 10th Ebola outbreak. And just before a declaration was made, there was a new case for Ebola. And they're yet to actually wait until they see whether actually indeed there'll be no more further cases of Ebola. So you can imagine in a context which has struggled with violence and with over 100 militia groups for more than 25 years, they've been struggling with their own internal security, now with Ebola and now COVID-19. The cases might not be significant, particularly in North Kivu, like any other context, but you can imagine, because the current COVID-19 has affected everything else, because schools are closed, social distancing is in place, all protection activities are going on in a context where community have struggled with stigma, isolation, and fear. And more so over the children who have not been able to have a proper education system, and they've not been able to fully go back to school just when they were waiting to go back to school, and then COVID-19. So this has just made it worse or more complicated and increased the level of distress amongst community members who are already struggling with violence and Ebola. As we all know, what has been happening in North Kivu, the situation is a bit different or unique because of the conflict and armed groups, and not only attacking community members, but also humanitarian workers. So when we look at elevated level of distress and basically the impact on the psychosocial well-being, not only for the community themselves, but also for humanitarian workers. And I traced back when I was in North Kivu in September, when I went in for my deployment, and actually left in December because of deteriorated security. And I have had to work offline with them remotely now because I'm not able to travel back. When I went to the health facility where we were taking in our vaccine, and I was chatting with community members there, as a practice, all humanitarian workers get their vaccine for Ebola within the health service. And when we chat with community members, they were asking me, why would you be interested to come to such a horrible place? I mean, why would you come as a female? Why would you even dare?
So what did you say?
A lot of hopelessness, you know? Yes, a lot of hopelessness. I mean, they think they have the worst. They think they don't deserve. They just think there's no future there. And when we had this chat in the queue waiting for the vaccine, you could see a lot of hopelessness, loss of energy, loss of despair, no regard for life. And they say, we're just doing it because of doing it. So you can imagine what COVID does to the current COVID does to people who already had no hope. They had not seen the reason. Yeah, so
well,
it only makes the situation more vulnerable, and actually not for only the community themselves, but even humanitarian workers working in this area, because they also don't understand why do we go there, yet this is a place which is really volatile. They don't understand why we need to go there, and that's why the whole stigma, the whole attitude toward even humanitarian workers is still an issue, because people have generally lived in a sense of hopelessness, in a sense of devastation. They don't look forward to anything. So you can imagine the impact on their psychosocial well-being.
Yes. Sorry for interrupting you, but this was a very vivid explanation of the situation. I will come back to you with, of course, the question that is burning in all of our minds, like how can you meaningfully do something in that setting? But that you will explain in a few minutes. I would like, before we go back to the first speakers, to Fahmy. Fahmy Hanna, you are the last speaker, but not the least. You are a technical officer in WHO, but you are also the co-chair of the IASC reference group, which is the main coordination mechanism for humanitarian MHPSS, IASC reference group for MHPSS. And in that capacity, you are closely involved in the work of country-level coordination groups, like the one that Deborah is leading, but in many other places in the world. So could you tell us a little bit what you hear from the colleagues in the field, and do the accounts of Ken, Deborah, and Phiona resonate with you? Over.
Peter, thank you, and thanks all colleagues for this opportunity. The mental health impact of COVID-19 on humanitarian settings is a catastrophe within the emergency. Let me share with you a personal story that in the first 10 days of March, as part of my role to support interagency coordination at global level in the area of MHPSS, but also in countries. So I had a request to be for the first 10 days of March in Yemen, the world's largest humanitarian crisis. My mission was supposed to end on 9th of March, but there was a lockdown that happened in country, and I was not able to leave. So I had to stay longer until 17th of March. When our mission first started in Yemen on 2nd of March, COVID was barely mentioned. COVID seemed distant from all humanitarian operation. Nobody was talking about it because Yemen got the largest number of people in need for humanitarian assistance in the world. Yemen got ongoing outbreaks of cholera, chikungunya, dengue fever, and famine, and ongoing active conflict every day. So COVID was barely discussed. And as we move with the days during the mission, the only topic, the only fear, the only distress among the population and among humanitarian was only COVID-19. And then I witnessed not only the impact on the population. Keep in mind, Yemen is the largest humanitarian crisis in the world, with largest number of humanitarian staff, probably anywhere, or one of the largest in the world in one country. But also with the largest humanitarian mental health needs. If 1 in 5 in conflict settings would have a mental health condition, according to WHO estimate, then there would be 7 million plus people in Yemen who require mental health support.
Those are unbelievable figures.
Unbelievable statistics, but it's the reality. But I witnessed with the lockdown, it's not only the population, but the staff who are not allowed to go in, and the staff who are not allowed to go out back to their families. The humanitarian staff and the unprecedented stress they have to deal with to support the population while dealing with themselves and worrying about their families back home. But
thank you very much, Fahmy. Can I because I want to have some time to discuss on the response, so I will get back to you in a minute. I have actually, for the second round, thank you very much, Fahmy. This what you added an additional layer of issues around the staff well-being as well. But in the second round, and we have around 16-17 minutes left, I would like to ask you the same question to all of the panelists. Basically, is what are you going to do now? So can you explain us in what way you and your colleagues are adapting the mental health and psychosocial support work to the new situation? So if you could do that in around 3 minutes each, to say what kind of adaptations to the new situation do you have? So I'd like to start with Ken. Could you say something about this?
Yeah, I'll speak in my dual role, which is I'm primarily a researcher, but researching implementation projects. So the first adaptation we made, we had to collect post-implementation or end-line data from 240 caregivers, 120 families, and Lebanon was a complete lockdown. People couldn't leave their homes, and some of the team were scattered because of their travels. I was in Amsterdam, one person was in Canada, another in London, the rest of the team in Lebanon. We had no way to collect data, and this is a big study that we were about to lose a lot of data, a lot of resources. And what we ended up doing was developing an entirely phone-based methodology of data collection that worked remarkably well. We were able to put phone credit on all of the refugee families' mobile phones, schedule 240 phone call assessments, and with a team of 17 people in 4 time zones, we in 7 days we carried out an assessment and gathered data from 94% of the participants. And it was remarkable, and it was really amazing too, the way the team, everyone in their own home, all the research assistants, all the coordination staff, we were able to support each other as well as the participants in the study. One person in our research assistant team got pretty overwhelmed by the combination of being in lockdown, this horrible story she was hearing from participants about the conditions of their life. And she needed a tremendous amount of support, but we were able to provide that all online in a way that by the next morning she was ready to go again. So from a research perspective, we've adapted, and we'll be doing another phone-based assessment starting next week. From an implementation standpoint, while the country's still in lockdown, we've been sending out intervention content through recorded messages to participants' phones. We don't know what kind of intake, what kind of use is being made. People are getting the messages, whether they're using the content, we don't know. But as soon as the lockdown lifts in Lebanon and we start implementation again, what we will do is simply ensure that we maintain 1.5 meters between participants in our caregiver support groups. And we've taken steps to make sure that we can do that. We have masks available for everyone who wants to wear masks. So it's possible for people to wash their hands and maintain good hygiene. So we think we're going to be able to continue implementing once lockdown lifts.
Right.
So that's how we've adapted.
That's a good story, and it's remarkable that you're able to do research in this context. So, yeah, let's go to Nigeria, because what I hear is Lebanon is a middle-income country, good reliance on telephone and mobile networks. How is it in the work that you do in Northeast Nigeria? How do you adapt your existing MHPSS programs to the new context? Over to you.
Okay, thank you, Peter. So really interesting also for hear from what can already explain. So from the Northeast Nigeria, I might link it to the issue that I already mentioned earlier about the stigmatizations. I think if Ken and also Phiona already mentioned about this. So there is a high level of stigmatization or social stigma related to the COVID-19 in Northeast Nigeria. I can share maybe there's this kind of like myth and misinformation that's spreading very easily within the community. Just an example of some people believe that it's a white people disease. So the Africans have more immunity to the virus, and the COVID-19 is not exist. This is what also they believe, and it's a way of like a government just imposing the regulation to take like more advantage from the poor people, and many more kind of like misinformations. So the adaptation is just like now we understand that talking with the community or the community engagement will be like really, really important. So in a complex setting like here, with more than like 140 IDP camps, and also we have another like urban area. So it acknowledged that the standard of COVID-19 prevention measure might be like really challenging. And in some case, even it's impossible to implement, like the hand washing, maintaining the physical distance, or self-isolations. So the risk communication and community engagement are very fundamental. And this is also a public health messaging for this setting, and it's a continuous activities that have been carried out by the MHPSS partner in collaboration with other stakeholders, in addition to provide and deliver their other basic provisions. So the Northeast Nigeria.
Deborah, how do you reach people then? Because there are many different languages, people are far away. How do you do that?
Yes, that's actually a really good point, Peter, because in the Northeast Nigeria, we also have like a really difficult setting. With some area, it's inaccessible or even having limited access to reach out. So to expand and to ensure about the key messages are reaching more location. So there's a various kind of way. So the use of radio programs. So we have like one radio can have like more extent reaching the difficult part or like the hard to reach area. So the radio program, we are using the jingles and radio talk in local languages. Of course, it's already like translated from the key messages with one of the big organization, for example, the Translator Without Borders working here for translation. And it has been regularly used, and it's effective to share timely messages and reliable information related to COVID-19 and its prevention measures. So as well as the government is seeking support from various mobile network providers and have a collaboration and inform the community with key messages. So we also consider that this is the momentum to see the essential of localization strategy or build the capacity of local organizations, because the MHPSS partner and humanitarian actor in here are working closely with locally recruited volunteers to continue the community awareness and sensitization in the hard to reach area and in the IDP camps during the lockdown scenario, as well as providing basic psychosocial support. So in addition, sorry, last one.
Yeah, go in. The last one,
last one. So last one is just like we have working with community leaders, religious leaders, chief of the village. We call it like bulamas and other powerful influencer as the key players to support the activity. So it's always relevant to observe and how the community is practicing their culture and rituals. And it's applied when we are sharing the key messages, for example, like not shaking hands or maintaining your physical distance, because this is actually social bonding.
Super
so
helpful.
Yeah, that's what we're doing. Yeah.
This is very helpful, and I find it very interesting also how you say that actually the whole COVID-19 pandemic has accelerated the community-based way of working. You have no choice. You have to rely on the people who are there. So I wonder how that is in the Kivus. Phiona, can you say a little bit how you, with World Vision and your partners, adapted your work? And can you still work actually? Can you do something? Over to you.
Yes, Peter. Yes, you can work. You can still work, because what World Vision has done and other partners is basically integrating our response with Ebola response and COVID response. As we may have already been aware that the current case of Ebola just made worse in terms of stigma towards survivors of Ebola. And of course, misinformation only makes people more vulnerable and not able to cope with their current situation, and also lack of appropriate information. And what we've done, for example, is one, we look at the broader aspect of responding to community needs other than just a psychological or livelihood, but looking at the response in a broader or in a greater perspective and addressing protection issues, security issues, access issues, which speaks to practical problems of community members. And these practical problems include what people see, because mental health, people do not really appreciate mental health. If you say want to psychosocial support is offered, people will not come for it. But when you integrate it into livelihood, into WASH, into other programming aspects, then you're able to speak to the practical needs of people, and they're able actually to think this is a good idea and actually think of otherwise in terms of coming and access to services. Also, the whole behavior change process towards help-seeking behavior. So as World Vision, that we look at the broader aspects of issues or needs and practical needs of community members beyond just communication. And then we have integrated radio programs to actually communicate to community members and pass messages. And as the greatest aspect that we have thought it really works well to address issues with stigma is working with local community structures at the village level. And one of the aspects is we use faith leaders through what we call a Channels of Hope approach. So a Channels of Hope approach is where we use faith leaders, irrespective of their religion, whether they are Muslims, whether they are African, traditional rulers, what speaks to their mind to address stigma and actually to pass information and address protection issues. So through the faith leaders, they run programs within structured community structures where they communicate issues about Ebola. Psychosocial first aid is a first line of response. And the good thing for us, psychosocial first aid, it only teaches them how to serve in a humane way and do the necessary referral and linkage. In the same area, we do have targeted intervention. That actually speak community needs. So we are implementing, for example, Problem Management Plus, and without Problem Management Plus is a good intervention because it builds a client or someone interested on how to manage their practical problems. So we have an area of Yes, sorry.
I have to stop you. It's horrible that I have to do this. But for the listeners, Problem Management Plus is one of the scalable psychological interventions, very brief, that can be done through trained lay providers. And it's good that you mentioned this, because actually what you say is also those psychological interventions still go on with some adaptations. Now, I would like to give the floor also to Fahmy. Fahmy, thank you, Phiona. I'll get back to you for your closing statement. Fahmy, you have a double hat, IASC, reference group, and WHO, and there are lots of tools that have been made to assist people to continue services. Can you say a little bit about the documents and tools that have been made?
Peter, thank you. Very, very briefly, I think what was really amazing is that from the very beginning, from early in February, the humanitarian actors came together to develop materials for MHPSS. So we had in February a set of recommended activities for MHPSS actor developed by the 57 member agencies of the ISC reference group, available now and translated in more than 25 different languages. We worked also in developing messages adapted for different target groups. And one of the very successful products was adapting a children's storybook to cope with children's stresses and worries related to COVID-19. And it became one of the most translated books ever, now available in 86 translations and used by actors in all humanitarian and conflict settings. For example, UNHCR used it in Rohingya camps in Cox's Bazar in a video format among children there, and almost in all humanitarian settings. we know that many of the coordination in countries moved online. So we start to receive requests for surge deployment in countries for coordination groups. So already there are requests for deployments remotely to support coordination in places like South Sudan, like Ethiopia, like Libya, and like Albania, and like many others. And there are key forthcoming products such as basic psychosocial skill guide, a guide for all COVID-19 responders from different sectors, how to integrate MHPSS into the response, and also an operational consideration document, which is a very practical document giving practical tips on how to adapt clinical services during times of COVID, how to adapt supervision to become remote, how to adapt mobile team while applying safe procedures, and also how to deliver services, MHPSS, for older adults, children, and other groups. So I think the really key thing is that this is a huge teamwork of more than 57 organizations that delivered these products with huge uptake in countries by colleagues translating them and using them.
That's great. And the people who are listening or viewing us haven't looked at the website, go to the website IASC, the Interagency Standing Committee. There are very many materials on mental health and psychosocial support, and we will make sure it's shared. Well, I don't know actually how we can share things, but go to IASC MHPSS and you will find a lot of materials. It's really interesting, and having been in the field, I must say that it is remarkable how this whole COVID pandemic has accelerated the attention for mental health and psychosocial support, and it doesn't stop us at all. Now, but time does stop us, so we have to go to the last round. So what I would like to invite to all the speakers to do is to give some closing remarks, just in half a minute, 1 minute, just to say what are key messages that you really would like the listeners to take home. And Ken, I'm predictable. I would like to start with you. What is your take-home message for the viewers?
I think we need to tailor our protective messages to the specific context that people live in. I think we need to ensure that people have the resources they need to stay safe. Clean water and soap, masks. Otherwise, we simply risk raising awareness of a threat that people can't protect themselves from. I think we can also focus on stress management. One of the real global adverse consequences of lockdowns is an increase in violence within families, violence against women, violence against children, because parents are very stressed out. And so we need to make sure that we are minimizing negative consequences of this grand social experiment, this shelter in place, because right now it's actually generating its own sources of harm. So I think through stress management, hopefully we can contain that to some extent.
Super helpful. That's thanks a lot, Ken. And yeah, over to Deborah. What would you want the listeners to keep at heart? Over to you.
Thank you, Peter. Yeah, I guess from our end is we understand that the COVID-19 pandemic is a global crisis that requires like global intervention. But however, it's important to consider that it exposes and increases the vulnerabilities of the community that have been affected by conflict, by war, or other like protected crises. So I think this is a really good timing for us to build a really strong system and foundation of mental health and psychosocial support, and appreciating that the MHPSS intervention are playing very significant key to support or enhance the resilience and the self-efficacy of the community to be able to cope with this current adversity with the COVID-19 pandemic. Yeah. Thank you, Peter.
Thank
Over to you.
So it's essential. It's an essential part of the response. That's what you say, Deborah. Yeah. Okay, Phiona, over to you. What would be your take-home messages for the audience? Over.
Yes, integrating mental health and psychosocial support in all aspects of the response, and task shifting to use or utilize community-led intervention, both targeted and also the lower levels of the pyramid, which are access points for any psychosocial support. And just appreciating that this time around during lockdown, communities can make a huge difference towards responding to mental health and the psychosocial issues in their community. So, and proper training with supervision. So as we enroll lay professionals or lay community members, let's ensure that there are structured supervision to ensure there is quality and also to protect further harm. Thank you.
Thank you very much, Phiona. That's beautifully said. Thanks a lot. It's always a pleasure to listen to you. Fahmy, over to you. What would you say are your key messages?
Peter, thank you. MHPSS is essential and basic needs. Let's make sure that it is integral part of every country humanitarian response plan. Let's make sure that it's part of building back better, and also it is part of country preparedness of building better before the next crisis happens.
Thank you very much. I'm afraid the time is up. We will stay a little bit online. I found it tremendously helpful, pleasant, and also exciting to learn these insights. What I hear from all of you actually is that MHPSS should not be an afterthought, should be integrated within the whole humanitarian response, not psychologizing everything. That's what Ken made clear, but the others agree as well. It is like integrating it within all the humanitarian responses that we do. And the other point that came out loud and clear also is that the pandemic forces us to strengthen the resources within communities and within refugee families and individuals. And we should do that anyway, but now we have to do, we have no choice. I mean, we are doing it. So let us hope that out of this horrible pandemic and the horrible aftermath of it, we also have some lessons learned and some things that we can build on, and that some good comes out of it. Ananda, it's over to you for the closing words, but I think we have to end.
Yes, thank you. On behalf of the organizers of the seminar series, I'd really like to thank all of you, Ken, Deborah, Phiona, Fahmy, Peter, for your thoughtful insights on the challenges faced by the populations that you and your colleagues are serving. The recordings and the notes of the session today will be posted on the website unitedgmh.org in the coming days, and I'd like all of you who are online to also join us next week for the webinar on the 2nd of June, which will be on mental health and children, youth, and carers with panelists from UNICEF, WHO, and civil society organizations. And you can register for the webinar for next week at the same site that you did for today's. And finally, I'd just like to invite all of you who are on Twitter to join us using the hashtag COVID-19MH, all caps. Phiona, Peter, and Ken will be online and will be able to respond to some of your questions and comments, and I will be able to post responses on behalf of Fahmy and Deborah. And if you happen to work in a humanitarian setting yourself, please do use the hashtag to share your own experiences. Thank you very much for joining today, and we hope to see you on Twitter and also next week. Take care.